Thank you so much to all three of you. This is a very, very important conversation on so many levels. And I have very much been looking forward to hearing from all of you. I think, and I'm going to refer to you by your first names, which you all very generously agreed to. So thank you for that. Rachel, I want to ask you, in your role as chair of the American Academy of Pediatrics section on nicotine and tobacco prevention and treatment, what do you recommend to patients or patients' parents who come in with kids who are suffering from this kind of addiction? And just the pre-question or the backstory that I also would love you to hear about is, it takes a lot to get a child who is addicted to even want to quit. So assuming that someone comes in ready to quit, I also just want to back up for a minute and say, from your experience, how do you even get them to that place?
So thank you, Meredith. That's, two incredibly important questions. So I'll answer the second question first. How do we get them to that place? The first thing is we need to start the conversation, and we need to do it confidentially. And I'm going to speak as a clinician, but of course, as a parent, and I have a 19-year-old myself, so I have some of that experience too. Having an open line of communication is always important. So the way, as a pediatrician, the way that I think is most effective, of course, is to have a confidential conversation. Just talk. There's many different ways to present this, but I think the most important point, and I think pediatricians understand this, is to hear from the teenager. We know that teens are going to engage in conversations and actions about their own health when they understand and when they consider it to be important to them. So that's the first thing, is to understand where they're coming from. What do they know about these products? What do they feel about them? Do they understand that they're harmful? Do they feel addicted? Are they worried about their friends? There's many ways to frame that. So the first thing is to have the conversation. It's kind of pointless to start recommending treatment for someone who absolutely will not engage with that concept. In that case, I go back. Now I work in an inpatient world, so usually they're with me for a few days. So I will go back later in the day or the next day, as my colleagues who work in an outpatient office might do. They will bring them back, soon to have a conversation. Again, I think that this is something we have to recognize as an addiction, or a potential addiction is not a one and done thing. This is a chronic disease now that we need to treat as such. And so we are very good at bringing people back to the office or revisiting issues on asthma, diabetes, all those chronic diseases we are all very familiar with. This needs to be considered in the same way. So that's question number one. Assuming that you have a teen who is engaged in the conversation and maybe considering quitting, whether they have initiated the conversation and said, I've had enough, I want to quit, or they're not quite there yet. There's a big spectrum. You're right. We don't have a lot of evidence-based treatments. We don't have really any evidence-based treatments. There's very little evidence, and there's many reasons for that. But these products hit us by storm, and they've become more and more concentrated. And so we're dealing with teens who really do need help, pharmacological help, for which we don't have any FDA-approved treatments. I will say this, that for the common over-the-counter treatments for people who are 18 and older, so nicotine replacement therapy. If you're 19 and you want to go buy patch gum lozenge, you can do it at pharmacies. You can't do that if you're under the 18. But while it's not FDA to do that as under the age of 18, a physician can give a prescription and it will be filled. And that is important. And that is supported by our policy statement, which was just reissued within the last year. Because again, understanding that lack of evidence does not mean we don't treat. It means we deal with what we have. And we don't know whether this is really going to work, but I think most of us who work in this space are going to try whatever we've got. There's many other options. There's the texting programs, there's behavioral therapy. So in general, I'm going to see what is, number one, going to appeal to a teenager, because if I give them a prescription and they won't take it, that's a pointless act on my part. But also to try to really do a multi-pronged approach, because we really don't know, and everybody's individual. So that's going to be my my brief answer on that. I'm sure the others have something to say as well.
Thank you. And you're referring, and perhaps we can even put in the chat, or we can follow up, or put it on the conference website, the American Academy of Pediatrics recommendation. It's not a recommendation, it's a guidance. There's a difference, correct?
Yes, yes. So it's called Considerations for Clinicians. I know Sharon was also involved with the creation of this a couple of years ago. The AAP partnered with the CDC actually, and there was a summit held with a number of experts, and really we all put our heads together and came up with guidelines that are based on the best evidence that we have, and those are available to all practicing pediatricians. And so what I would say to a parent is, you don't have to do this alone. You shouldn't be doing this alone. Go to your pediatrician, and this guidance is at least available to pediatricians to use, and it's updated and it's on the web.
Thank you. Sharon, I'm going to go to you next. You're, as you know, in your chief, the Division of Addiction Medicine at Boston Children's Hospital. What have you found is helpful? And Rachel, your point is very well taken. It has to work for the individual. You know, as a parent, to hear, well, we don't have, quote, FDA-approved treatment plan sounds like, oh my God, no one knows anything and there's nothing. And what do I do with my kid who's so addicted? So it's very stabilizing to hear that that doesn't mean that there's nothing that can work or that will work. And I would be curious to know, Sharon, what you have found over these last few years that does work. Is it an individualized plan, et cetera? I'd love to get your perspective on that.
Yeah, thank you for asking. And I want to start by agreeing with what Rachel said. I'll try not to repeat too much of what she said, but she laid a lot of it out there. The one thing I want to start with is that in some national surveys, about more than half of kids who report vaping in the past year said that they are thinking about quitting or interested in quitting. So I just want to put that out as hope there. Now, parents may not experience it that way, right? Because you can have a 16-year-old who's sort of thinking about quitting, and when the parent comes and says, get rid of that vape and you need to quit, like they might retract. And, so I think, just like Rachel said, some of it is doing it at your child's pace, right? So parents are in this awkward position of needing to really set some firm limits, right? And and at the same time, encouraging their children to take advantage of whatever help and supports are out there, right? So it can be a really tricky position to be in, I like to think of that as hard on the problem, soft on the people, right? So, if there's a way that we can do that and get them, speak to somebody, I think that's where we really have the magic happening, right? That's the sweet spot. In terms of treatment, for kids who are interesting or at least willing to make an attempt, we usually recommend nicotine replacement therapy as first line. There are other options that people use to quit smoking, right? There's varenicline and there's bupropion. So there are other options that can be considered after a chat with a medical provider. I like to use nicotine replacement as first line because I think it's pretty easy. It might sound crazy to people that we use nicotine to treat a nicotine use disorder, right? Isn't that just giving more nicotine to somebody who's addicted to nicotine? Well, the good news about it is that, nicotine is a chemical that can be addictive, of course. We know that, right? We know that cigarettes are very addictive. Vapes are very, very addictive. But when something's addictive, it's not just about its chemical composition. It's also about how people are taking it into their body, right? And so with smoking and vaping, we're delivering this very high peak of nicotine to the brain. And when we use other forms of nicotine replacement, like patches or lozenges, I like to use them both at the same time, actually, or these other forms that are FDA-approved forms of nicotine delivery. We know that they're not addictive because they've been studied by the FDA. So, and the manufacturers have shown that there's very little addiction potential, even though it's the same nicotine. The way it's given is really important. I just want to get that out there for parents who may be confused about that. So, the biggest issue is actually, getting the medication into a young person, right? Because clearly it can't work if they don't take it. And then I will just also say, because you asked me what works, and so I think big picture here, I think of all addiction treatment as ideally composed of three components. So there's the medical piece, which we're talking about, which includes things like identifying and treating withdrawal symptoms, suppressing cravings. Sometimes it can involve counseling from a physician or a medical person, medical professional, and those kinds of components, depending on what the problem is. There are also this a role for supportive counseling, right? Often medications help to suppress cravings, but they might not get them down to zero. So working with a counselor who can help you figure out ways to get through them without using a substance, right? For people who are trying to quit, and also trying to understand what the substance use is doing in their lives. Some kids use nicotine because it helps them study and focus, and others use it when they're feeling sad or depressed, right? And so just trying to understand that a little better and really try and get to the roots of some of it. So if we can package that together with the medical piece, and really, so that might be meeting with a behavioral health counselor. If that's not available, there are some free electronic text message services, which, I think that if I had a choice, I would take a live person. But if I couldn't get to a live person, there's been some, the text messaging services have some efficacy. And then finally, the last piece of gold standard, I would say, addiction treatment is a behavioral component, right? So there's the medical component, the counseling or support component, and then behavioral component. That's learning to re-navigate your community safely, right? So in adults, that's often peer support. With kids, that's often a role that's taken on by parents, right? Of parents who are there to set firm limits and also monitor kids, and also be there to give positive reinforcement to their kids for making the effort to try and cut down, to be there to celebrate when milestones are reached, to fill in all of those pieces. So, I think if you can put that package together, that's really the sweet spot.
Right. Thank you. I want to talk about the behavioral piece. And James, I'm turning to you as director of the Duke Center for Smoking Cessation and director of the Duke Smoking Cessation Program. The legal age now to purchase tobacco, it was 18, now it's 21. And so, we know that certainly among a lot of the early adopters of Juul and the products that followed, often parents don't even know their kids go off to college. When there is this sense among youth, or let's say, youth / teens, college students, that quote, everybody is doing it. And in this case, it's not literally true, but it's, close to literally true. How do you treat for the holistic, how important is the behavioral piece? Because, all of you, so far, and I know that you would agree, there are medical treatments, the nicotine replacement therapies in different forms that can take care of the physical addiction. But is this, given the numbers and the scale and the age group, is this much more complicated because there's a social component, and how do you treat for that?
That's what a great question, Meredith. Thank you, and thanks for having me. And the first thing I would say is that I would like to give a strong ditto and hooray for everything that has just been said by Rachel and Sharon. What excellent comments. Yeah, there are absolutely important considerations with regard to this population. And one of the first things is something that Rachel pointed out, and that is that each person, and I'll say each person that I see who is a young person who is using e-cigarettes, who really has unique challenges. And just to give a sense of the breadth, you may have somebody who is really surrounded by other people who are using e-cigarettes, and that continues to trigger them. And that's the primary issue. It's going to parties, it's social engagements. You have other people who are actually relatively isolated from others who smoke, and their primary driver may really be physical. And they're really addicted. And there are other people for whom it's a combination of alcohol and e-cigarettes, or cigarettes and e-cigarettes, or hookah and e-cigarettes, and then we get into opioid use and other chemicals, and then even further still, we have people who have anxiety or depression, and all of the psychiatric challenges that a young person has will become intertwined with nicotine addiction in different ways. And so there's some complexity there. So I think we need to start, and just going back to what Rachel said earlier, we need to start with the fact that this is never a one size fits all. You really have to understand the story that this single individual is giving you, and then try to work together with them to develop a treatment plan. In terms of kind of, what works from a behavioral standpoint, and kind of what seems to be effective. The first thing, and again, this is something that was already brought up, but I think it's so important. The first thing is buy-in. Early on, as people are developing, in my experience of these patients, there is quite a range of buy-in. I run into patients, people who are desperate to quit, and they're already trying everything, and they're all on board, and they're willing to give it their all. And I come into contact with others, and they essentially say, well, my parents want me to quit, but I'm not sure if I really want to quit at all myself. And that's another starting point. And we as providers, we need to jump into the ring with our patients and be there supporting them, and not be shaking a finger at them, and accept them for wherever they are, and take them at whatever pace they need to go at. And that can sometimes be hard when we feel like, oh, I love this person, I just want them to stop, and I want them to stop yesterday. We need to put that on the shelf and say, okay, let me get on board with where you are and what your time scale is with this. And I've found that some people are ready to quit, make a quit attempt right away, and some people really need some time to prepare for that, and need to slow down over time, and need to work more organically. To kind of come back to something that Sharon was talking about, the behavioral work that we do with patients really needs to be integrated with medication treatment, and sometimes with counseling also, and really bring those together. The evidence around nicotine dependence in general, which is mostly really studies around smoking, but it really shows very definitively that we need to provide the most effective care. We need that behavioral side, which is counseling and behavior modification, together with medications. Young people, and we sometimes don't want to admit it as parents or even providers, but young people can show up with real, genuine addiction. I can have somebody who's 16 years old or 18 years old, and just because they're young doesn't mean that they don't have full-on grown-up addiction. And what that means is that if they stop nicotine, they go into withdrawal. These people, you can't just tell them to cut it out. It's not that simple. It actually requires engaging them and working through the process of addiction. And again, often the most effective treatment for an individual will be a combination of medications and behavioral treatment. There are multiple treatments that have been found to be effective for tobacco use in general. There's cognitive behavioral therapy, there's mindfulness, which has been helpful. There are simple strategies around identifying triggers that lead someone to use an e-cigarette and avoiding those triggers. Strategies for what do we do when an urge arises and how to manage that. We don't have enough time to go into each of those, but I will say that it's very individual, where you identify what the person's challenges are and then start to work with that individual.
So I guess, all of this makes perfect sense. But not every parent either knows that their child has a serious addiction, understands, as you said, that while they may be a child, like, just stop. They may not understand the level of addiction, even now when there's been so much conversation and sort of, focus on this. And then the other thing is that not everybody has resources. I mean, we always encourage people, the first thing is talk to your pediatrician, because when a child is younger, right, that's the parent, that's your partner in all of this. As these kids get a little older, they go to college, I wonder, like, we're focused on youth. Is there ever a turning point whereby if you don't get someone help when they're young and they, quote, age out of the youth category, let's say, an early adopter of Juul, let's say, who started when they were a junior or senior in high school in 2016, and they went off to college, does that mean we've missed the window and they are going to have lifelong addiction, number one? And number two, is the treatment, let's say, 5 years from now, that adult wants to finally treat their addiction. Will an adult be treated for this kind of addiction differently than the cohort of still young people, 21 and under, that we're talking about? Because I think a lot of parents, we get these emails every day, and we all of us who are working on this or are interested in this have some kind of personal experience. And there is so much desperation out there and so much exasperation, like lots of different kinds of things are coming out. Try breathing into this. It's a necklace you can breathe into. Try this. It will calm you down. Suck on this. It's an oral fixation. But there's no perfect fix. There's the combination. So I guess the question really is, what if you don't have access to the best and the brightest minds who can explain this to you? And you're just a parent doing the best you can, which is what we all are trying to do. What should parents do if they don't have a pediatrician who they trust or that is as engaged in this work? I mean, I think that AAP has done a great job of spreading the word, but what do you do? And what do you do, by the way, also, and I'll toss this to both of you, if your insurance won't cover the behavioral therapy that your child needs, in addition to ultimately, if, let's say, you're not just using a nicotine patch or a lozenge, but let's say your doctor prescribes Varenicline, which is the generic Chantix. And I know, James, we've discussed that, for this kind of addiction for young people, it's not just your regular dosage for a certain short time period, because it's so much more addictive, which, Sharon, you alluded to, we all did. What do you do then?
I'll start, and then maybe I'd be interested in also the others' thoughts. But so we, in my work, we routinely encounter people who have no insurance or who have pretty limited insurance with very high copays, and end up having to pay most of their way. And and we come up with all kinds of creative solutions and kind of do our best. The reality is that this is just a deeply difficult problem in our world, and there are not simple solutions. I wish everyone could see, a wonderful, amazing providers that are available around the US. But a lot of times that requires insurance to see those people. The free programs that are available, the telephone-based programs, the telephonic quit lines, the text-based programs that have already been mentioned, I think are an excellent avenue for treatment, for free treatment. I'm not going to say that it's as good as sitting down with somebody face to face and getting on medications and all of that, but it's a lot better than nothing. It's a lot better than nothing. And as as Sharon was saying, there've been studies on say text-based programs, and they are effective. They're more they're more effective than nothing. So I think I don't think it's I don't think that there's a simple or an easy answer for this, except to kind of do the best you can with what you have available.
Sharon, what do you think has to change? I mean, as James is saying, and I think we would all agree, this is a deeply difficult problem, as you said, James, without a simple solution. The last thing anybody wants is, once again, in this country, those who have insurance and those who don't, the haves and the have-nots, people who are able to get the help that they need. What has to happen? Is there enough funding for research in this field? Is there enough focus on, getting evidence-based research? Like, what do you think right now is the most important thing that has to happen so that we can help these young people who are suffering from a very serious addiction?
Yeah, a lot of really good and important questions here. So, first off, I want to respond to something you had brought up earlier, and that is, like, what happens if we miss them in this vulnerable window? Well, whether we catch them in this window or not, I mean, of course, the earlier we treat any disorder, the better, right? I mean, there's no disorder where we say, well, yes, you have asthma, but let me wait until it's really bad before I give you, something. Like, it wouldn't make any sense, right? And so, for addiction is like the one condition where we really think about doing that. But regardless of when your diagnosis is made, addiction is a chronic relapsing disorder. Okay, now that's very depressing sounding. And on the other hand, that doesn't mean that people can't quit and stay quit for a lifetime. What it does mean, though, is that a lot of people even people who've quit and have quit for a long period of time, need to stay connected to some level of treatment, right? Some level of support, be that some counseling, however it is that they're doing that. We need to understand that addiction is really a chronic disorder, and we can't treat it with an acute disorder model. Just like we wouldn't say, okay, you have diabetes, so but I've treated you, so you're fine. You should, that's just really not the model. So, which actually just complicates the question of, so what do we do and where do we get the resources? I think that we need to acknowledge that, we need to understand that, and when we're thinking about solutions for how do we pay for this and how do we sustain this, that we need to think of it as something that's going to happen over the long term. Doesn't mean people will be on medications for the long term, but often people will need some level of support for the long term. How do we do that? Well, I do think that we do certainly need more research on the topic. We know something about quitting smoking, right? Smoking's been around for a long time. We know less about quitting vaping. I talked a little bit before about that even though the nicotine molecule might be the same, the way it's delivered to the brain actually makes a huge difference. And those differences can actually impact things like, how we use medications or how we do other things. And we really just don't have enough information on vaping. And, I want to say that, that Juul hit the market in 2015, 2016, and we saw all these kids take it up. We recognize this is a real crisis, and now the FDA is regulating these products. So we've made some progress. At the same time, vaping has not gone away. I feel like it's gone out of the news, but it has not gone away. We are still seeing, actually vaping really changed the way kids use both nicotine and cannabis, and it fundamentally changed the way kids use these substances. And even though you might not see fancy Juul ads with young people anymore, because those have been pulled down and some of the flavored pods have been pulled off, I can tell you that kids come into my clinic every day still vaping flavored disposable pods and flavored disposable e-cigarettes. So what I would say is, yes, we need more research to understand how to treat people better. The problem, even though it's not as visible anymore, has not at all gone away. And B, we need to continue to work on issues around regulation, because again, I think that there was this big dramatic story around Juul, and they were sort of identified as the bad player, and so and I think there was maybe they did some things that really accelerated the problem, but they're not the entirety of the story, and we're not done yet. So we need to keep working on that as well.
Right. Talk about preaching to the converted. I think that we all, I appreciate your saying that, because we all know that Juul, opened this public health Pandora's box, and the regulatory delays allowed it to remain open. And God forbid, it feels in this moment, with so many millions of kids using these different products, the bad actors that followed Juul, that what if we can never close it? Which is why I think the discussion about cessation in particular is so urgent and timely. And so, Rachel, I saw you nodding. I mean, you're seeing lots of, especially as a pediatrician, I'm assuming that we all agree, of course, with what Sharon just said. This is still a big problem. There's still predatory behavior out there. One thing I sort of wonder, when people talk about FDA-approved treatment plans, I know I should have probably asked this at the beginning, how important is that really? I mean, you've all sort of said, something is better than nothing, but is it like there's a magic pill, like, one day, years from now, there will be a quote FDA approved treatment plan and poof, everyone's fine? It's not going to work that way, is it? Or is it?
Yes. So thanks for that question, Meredith. Yeah, I'm kind of smiling because no, there's, if there was a magic pill, somebody would have done it, and we'd be all, that person would be very rich, and we would all be jumping on that bandwagon, right? But I think we've all established that nicotine addiction, and we've known this for decades with smoking, is a huge issue. And I mean, we also know that the majority of people who are nicotine addicted, at least in the research with smoking, start before the age of 18, which is why as pediatricians, this is our problem to own. And we really do want to get in there early. That is not to say that it's hopeless, because we will never stop trying. The FDA approval, I think, gives us, of course, credibility. It gives us more freedom. It gives, there are some of my colleagues who understandably, who may not be as familiar. They don't work in an area where they're seeing this as much, or they don't realize it's as prevalent. They may not be as comfortable sort of writing prescriptions that are not FDA approved for kids, even though we do this for many other conditions. And so I think that the FDA approval gives a stamp of approval, of course. It gives us the freedom to move forward with things that we hope are going to work. It also gives us the opportunity to really study them in a more rigorous way, because it's hard to study things that are not approved. And so there's sort of a catch-22 there. I want to just back up for just a minute too, to address a couple of the other things that were said. Sharon mentioned the co-use with marijuana or cannabis, and that's very high. We also know, James mentioned anxiety and other, comorbidities. And I think that some of the things that we deal with on a day-to-day basis are the fact that teens are going through a lot now as well. I mean, certainly I'm seeing a lot of teens coming in with anxiety and depression, and we know that from some early studies with these products that they are probably exacerbating that there's an association with worsening anxiety, even psychosis. And, you know, the cannabis literature is looking at that. And just last week, I had a patient who was admitted to the hospital for a different reason, but was, you know, I realized very quickly that he was withdrawing from nicotine, and we talked about it. And he said, well, I need it because it's, you know, his life was very stressful. And I said, well, when you think about how the withdrawal makes you feel, it makes you feel the same as being stressed, doesn't it? Because it makes you feel like, he said, it made him feel like he was having a panic attack. I said, you have to realize the only treatment for that in your mind is giving yourself another dose of it, which is exactly the path he didn't want to take. And so sometimes education is so important. If we could educate ourselves out of this mess, we would have done it. So that's not the only piece, but just as a takeaway, you know, teens and young adults want to be in control of their bodies. They don't like to be controlled by the industry. They don't like to be controlled by their parents. Certainly, they don't like to be controlled by anybody. This is their destiny. The education is a piece that they definitely want, and there's a lot out there already. And I think that is one place we can turn to as an adjunctive modality that can involve parents too. They can go on this journey together to be supportive, because we don't have a lot at this point. And so I think that's an important thing to remember to keep us moving forward.
Thank you. I just want to ask, you mentioned, and any one of you could answer this. One is that we have heard in the past that there are practitioners, you know, clinicians who are using off-label anti-anxiety medications for young people who are suffering from this kind of addiction. So I wonder, I mean, we talked about, you know, things off-label, like using for kids under 18, the nicotine replacement therapy. I just wonder if that's something that you have thoughts about or have used. And then the other thing relates to sort of the behavioral piece that James, we were talking about earlier, which is there, have you guys ever used, or do you hear of the peer group model working in this context? And that may be, you know, let's say you're a young person in college and you're, you know, is that helpful to think about quitting with a group of friends, or maybe even just a group of families? Is that something that can work or could work, or is it something that people should be trying? And anyone can feel free to answer either question.
Well, I can answer about peer groups. You know, group therapy is it's a developmental preference for young people. We do an awful lot of it. We think it works really, really well. You know, I think that it's important. We use a facilitated model. So there are adults, healthcare professionals in the room kind of listening, keeping the conversation on track. But I think that it's, you know, an extremely effective methodology for, you know, or modality for most people this age. I think one of the issues is that they're very hard to access. I will say that, in my opinion, virtual care is making that a little bit easier. It's actually a lot easier for people to get to a virtual group than it is for an in-person group. So I think that is potentially a bright spot that you know, can be developed more, but seems to me an obvious area to build out resources.
Thank you. Does anyone else have any thought? I'm thinking that the virtual peer group, we have a private Facebook group for parents, and probably you know, having a virtual peer quitting group is something that should be explored more. That's great. Thank you. James, were you going to add something, or?
No, I'll just to kind of chime in on your on the first part of your question, which was you know, using anti-anxiety medications. I stay a long way from benzodiazepines and addictive medications in people when I'm trying to work with addiction. And if I have to use a medication to manage anxiety, it's going to be something like an SSRI or something like, you know, one of the medications, but those take a long time to work for anxiety. And so they're not, you know, they're not perfect. The thing that I have found, and I just want to just to kind of jump in on this a little bit, is that young people who are starting to use tobacco, sometimes they respond a little better to different doses of medications. I'll use, for instance, the use of varenicline. I'll use low dose varenicline in younger people. There's a study now that showed not statistically, but numerically superior results with lower doses of varenicline in smokers. And I think people were just tolerating it better in the studies, and I've seen that in my patients as well. But regarding anxiety or depression or other psychiatric illness, if I feel like that is a real challenge and really tied in closely with their tobacco use, I want to work hand in hand with a psychiatrist and a psychologist. I want to be a part of a team that is working with this person. And that's relatively common, that kind of intertwined presentation.
Thank you. Well, I really appreciate the wisdom, the great wisdom and compassion and all of the really hard work that all three of you are doing in your capacities as remarkable clinicians and providers of really important care. I just want to end with something that I know, James, you and I have spoken a little bit about this, and I sort of want to put it out there, because there is no FDA-approved treatment plan. And because different people need different things, and insurance, you said that you have to come up with something because insurance isn't going to cover it. What would be helpful to hear from someone, at HHS or FDA? What do we need to hear so that when someone's insurance says we won't cover this because there's no approved treatment plan for youth addiction to nicotine from e-cigarettes, is there something that we can ask to have stated or said so that there are places we can then say to our insurance providers, listen, my kid has this, and in the absence of an approved treatment plan, I've been told to do this. Like, what can we as parents push for or advocate for? One, so there's more, support and financial support for research into this, because there are millions of people who need help and answers. And is there something that we can do to prevail upon people in policy positions and positions of influence, so that people are not forced to either not get what they need because they can't afford it out of pocket, or to pay out of pocket if they're lucky enough even to have a provider who is creative enough to come up with something that is not approved? What can we do as advocates, as parent advocates? What would you suggest we do? Other than have a march on Washington and demand that FDA focus on this. And I say that with all respect and admiration, as we know, Brian King has participated in our conference, but I think people just feel scared, frustrated, and helpless. And we never want parents to feel alone or helpless when they're dealing with this problem.
I wonder if any of us is really willing to answer that, because I don't think there's really a good answer. I mean, you hit it. In my mind, Meredith, you hit it when you said more funding, because, I do appreciate what Brian King and the Center for Tobacco Products are doing. And government works in a certain way. And I don't think anything will happen if there's not evidence behind it. Historically, that has been the way we've worked. And I will say, in conversations I've had in fighting for more funding and more attention to this issue, is that when we look at the what we know about smoking, it took decades to discover, through all the research that was done, just how incredibly bad it was. And you see how well we've done as in public health measures and really sharply decreasing the prevalence of smoking. And we've done a phenomenal job, addressing the morbidity and mortality. We're not there yet, but we've really improved that. And the line I will use is, I don't want to wait 50 years experimenting on kids. And so what I would push for is, and I'm not sure that this is actually even in the FDA's jurisdiction, honestly, it's research funding. It's research funding from all research foundations. And so those of us who do research can come up with the data that will then inform the decisions. And I think, actually we've had conversations like this, that we are going to try to keep pushing for for obviously for policy decisions in the absence of that, because we can't wait 3 decades, and we're doing a lot, but there's a lot of research that's come out in a really short period of time, which is great. We need more, and we need to sort of be able to continually reinforce each other's experience in the real world, even if the true research is not there.
I would just add it's a little bit of a difficult time, in the government. And a lot of NIH budgets were cut. That has direct impact on our ability to continue to do this work. So, if people want to do anything, I would say, this is my opinion. Write your congressman, tell them do not cut the NIH budgets. We need this work.
James, do you have anything to add to that? I appreciate, I didn't mean to put anyone in an awkward position, but it's very helpful to hear what we can do to support the really important work that you and your colleagues are doing.
No, I completely agree. I think funding for research is really important. This is not really the role of the FDA, but I think any kind of statements that are public statements that of understanding, to say that until we have FDA-approved treatment for e-cigarette use, it is understood that providers will be leaning toward the existing voluminous evidence on nicotine dependence and tobacco use that we have through smoking cessation studies. And the FDA can't simply get behind something that doesn't have evidence. It's not that simple, but they can say, until then, this is the best we have. And I think that's because that's what honestly we're all doing, is kind of doing the best we can without the evidence that we would really like.
Actually, can I just add one more thing to that? Because I think, another thing the FDA can do is more regulation of these products, right? It's taken forever to get, some products that clearly should not be on the market, off the market. They're still there. They're still tempting very young teenagers. And I think that is a direct result of the FDA not having enough budget to really tackle this problem. So that's another area people can advocate for that would have a direct impact on their kids.
Well, we're on top of that, and we will do more of that. And I really want to thank all 3 of you for joining us, for spending your very precious time, and for caring so much and so deeply about helping so many of our kids who are suffering in this way. So thank you, all 3 of you. We're honored to have you. And hopefully, if we have the same conversation a year from now, there will be a lot of progress made and more, hopefully, evidence-based research. But until then, we are going to rely on you and your remarkable colleagues to treat all of our kids. So thank you very, very much.